The room is now muted.
Thank you. That line on. Mine's up. Yeah, I see it. Okay. Yeah. Good morning. It's 9 o'clock. We'll go ahead and call the Nevada State Board of Health meeting to order on Friday, September 6th, 2024. This meeting was posted in accordance with the Nevada Open Meeting Law. May I have a roll call, please?
Good morning, Dr. Pinnell.
Good morning.
Dr. Pinnell,
Present.
Dr. Morawski,
Present.
Dr. Ponce, Mr. Smith,
Present.
Ms. Belza Vinua, Mr. Cartwright,
Present.
Dr. Pinnell, we have quorum.
Okay, thank you very much. The Board of Health will provide public comment periods in compliance with the requirements of the open meeting law. The public will be provided with an opportunity to provide specific public comments for individual action items at the time of that board's consideration of that particular item. Comments provided during a specific agenda item must be limited to topics relating to that item. Further, the public will be provided with an opportunity to provide general public comments prior to the adjournment of the meeting. Persons making comments will be asked to begin by stating their name for the record and spell their last name. Because of time considerations, each caller offering testimony during this period for public comment will be limited to not more than 3 minutes. Use of obscenities or other behavior which disrupts the meeting to the extent that its orderly conduct is made impractical may result in the forfeiture of the opportunity to provide public comment or removal from the meeting. Agenda item number 2 is approval of the minutes from June 7th. In conversation with Dr. Morowski, he and I have some questions that we would like to ask the division staff. And so I would like to table the minutes until we can do that, and we will present those at the next meeting. Ms. Tags, do I have to have a vote on that, or are we okay?
You're okay to table it, but I would take public comments since it is agendized as an action item.
Okay. Is there any public comment on the meeting minutes from June 7th, 2024? There's no public comment in the South.
We have no public comment in the North.
Thank you. Next, we'll take our quarterly county and district health reports, starting out with Carson City Health and Human Services. Dr. Colleen Lyons, Health Officer, and Nikki Aker, Director.
Good morning. This is Nikki Aker with Carson City Health and Human Services. And you received my comprehensive report, and I'll just highlight a couple of things on here. I'm happy to report that we did get some hard to recruit positions filled. Have one more, unfortunately, to add to this that we just have found out since the report was submitted, but we again are going to be looking for an environmental health division manager. So we've got some pretty big shoes to fill there. So we have that posted now. So if you know of anybody, send them our way. We are getting ready for our community flu outreach events that will be starting in later September, October. Last year, we did not go into the schools, and mind you, we do this in Story, Douglas, Lyon, and Carson City, Story, Douglas, and Lyon counties. And this year we are going to go back into the schools. What we have found is that our vaccination uptick of our school-age children had decreased because we were not in the schools. So using that information, we decided to go back in, and not all the schools are letting us back in yet, but we're working on that, and we'll get back in there. We're also going to be vaccinating at senior centers, long-term care facilities, and some other private sector agencies, including DPPH here in Carson. So happy to do that. Within our clinical services division, we had a long time employee retire, our advanced practice RN. We do have another person in that place now, and things are going well and getting her trained. And we are making some changes within our clinical services. We're doing a quality improvement project, and we noticed that our patients numbers had decreased along with the number of visits, which is understandably. And so we are looking at being open for appointments early in the morning than we had been, and later in the afternoon. And then we will be open during lunch. So that's going to be a QI project, and we're happy to provide more opportunities for our public. In our chronic disease division, we are back in the schools and in some other agencies doing adolescent health. The staff are really pleased with what we're doing there. So I'm happy to be back in there. Under our tobacco control and prevention program, with our SB 118 money, we are going to bring youth vaping prevention back and include that in with our presentations and have workshops for parents and any public members. And through a grant we got for opioids, we're going to couple opioids in there as well. So we've got feedback from school faculty that they want the entire package of substance abuse. And so now we're going to be able to do that with grant funding. So in our H division, we've got so all of our inspectors are trainees, but they are progressing very well. And I'm very pleased with that. We are continuing to do inspections in Douglas County as we do in Carson City. We also do mosquito abatement under that division, and actually starting today, we have a seasonal vector control technician that started. And so we have not had anybody dedicated to doing mosquito abatement. And that just became the role of some of our environmental health specialists. So very happy about that. And that was made possible by some of the funding that we got passed through DPPH. Our EPI division, I think as I've reported in the past, we've been able to expand that program, and they're going out and doing some education for our schools and public health nurses around our counties. And we are seeing a little uptick in COVID right now. We're experiencing some of that in our own agency, but nothing that is alarming or of concern. And as you all are aware, we have human services under the roof over at my agency, and we have introduced a street outreach program, and that is contracting with a company up in Reno. And we have an individual that comes out daily and connects with our homeless and connects with them every day until that trust is there, and continually asks what services they need and how we can help. So that program is going well. We've done cleanup projects, cleaning up encampments and that, and those individuals that are helping with these cleanups are actually the individuals that are homeless on our streets. So we have been, I don't know if anybody here has a chance to go to any responsible giving presentations. We're going to work on that title of that program, but what that program is about is how should we be giving to the homeless? Should we go out and give them food in the park? It's not a good idea. That creates more trash. And sometimes the individuals, they won't eat it all, and then it just becomes trash in our city. So it's talking about giving to the social service agencies instead of giving to the homeless person themselves. We all are, we have many very caring individuals that will give clothes, sleeping bags, tents, all kinds of stuff, and that just increases their footprint, which makes it harder to get them services and off the street. So we're going to be doing more of these presentations. The individual that does the presentations has experienced homelessness and drug addiction, so is very well versed in the topic. And I've been working with the homeless for a long time, and I learned a lot of new things. So as those presentations become available, I'll make sure you all have that information, and would love to have anybody join us. Let's see. we are in the middle of working on our strategic plan for Carson City. We'll have that done by the end of December. We do have a contractor, Arc Dome, in which many of you know the principal owner of that, Caleb Cage. We're very excited to be working with him. And so he's looked at our community health needs assessment and our improvement plan, and we will put together our strategic plan of what Carson City can do, or excuse me, Carson City Health and Human Services can do as far as working on that improvement plan. And I'll stop there and take any questions.
Thank you very much, Ms. Aker. Are there any questions from the board members? Okay, thanks so much.
Thank you.
Next up is Northern Nevada Health District. It lists Kevin Dick, but I thought he retired.
Good morning. For the record, no, I am not Kevin Dick. My name is Erin Dixon, and I am the Deputy District Health Officer. Kevin officially retired in July of this year. Our new health officer, Chad Kingsley, apologizes that he is unable to be here today. You do have our full report in front of you. I just want to highlight three brief things. Back to school immunizations is always very big. We held 2 Saturday events right before school started. So in addition to all the other community events and our daily immunization clinics, we were able to support approximately 450 students getting back into school on time with approximately 1,000 vaccinations. Very proud of that effort. Our public health preparedness team training and exercises are ongoing. And we also held a mass casualty incident, a full-scale exercise that was held in collaboration with all of our regional partners, and that was a very large success as well. Our environmental health food program held a community resource fair for individuals interested in food permitting. This was the first we've ever done. It was very well attended. Assistance was provided for all aspects of the process, so even including how to apply and get a business license from the different jurisdictions that Northern Nevada Public Health works with. And we had individuals there helping people fill out applications. We even had examples of what food trucks and food carts met regulations that individuals could tour. If they already had a food cart or a food truck that hadn't been through the process, we provided a preliminary inspection and let them know what they would need to change to have it meet regulations. And finally, our temp food event season is in full swing. The rib cook-off wrapped up this past weekend. And for those of you who aren't aware, inspections occur throughout the day, but they start at 5:30 in the morning. Because we allow food to be cooled and reheated, our team is out there from 5:30 in the morning, and the evening inspection can actually finish after midnight. So many thanks to the team that works so hard to keep this really fun event safe for our community and visitors. And those are the only highlights I'd like to share. I'm happy to answer any questions if anyone has any.
Thank you very much. That is a long day. Are there any questions or comments from board members? Hearing none, thank you. Next is Southern Nevada Health District, Dr. Furman Lagoon.
City Law. So, good morning. For me again, Southern Nevada Health District. Well, I will refer to some highlights of our quarterly report. First, I want to mention that we had in August 1st, we have the Southern Nevada 2024 Substance Misuse and Overdose Prevention Summit. We had a large attendance at that summit. We more than 200 participants. This event was a partnership of the Southern Nevada Health District with community partners such as the PAC Coalition, also the Nevada HIDTA's Overdose Response Strategy, and the Nevada Institute for Children's Research and Policy. We have participants from not just from Nevada, but also from the region here, and also from the New York and other states across the country. So next year, we actually, because of the growing attendance to this event, we are planning to look for a larger venue so we can attend that. I also want to mention that during the week of August 4 to 10, we celebrate the National Community Health Center Week. Actually, Southern Nevada Health District has the dual duty of having a public health entity and also including a federal qualified health center. Our health center delivers primary care services and also includes Ryan White HIV services, refugee health, sexual health. Also, we deliver pharmacy services, telehealth, and enabling services. I had to mention that during the year 2023, our health center served more than 9,800 patients, and 48% of those patients are uninsured. Actually, our health center brings a huge value to our community. As in terms of dollars, I can share with you that our services actually save more than $2.8 million to uninsured patients who otherwise might have been unable to receive those services. I also would like to share that we started a very important project which is called Credible Minds. This is a behavioral health related project, and actually what it does is it provides online access to the community for behavioral health services and resources. This is a service that is free of charge for the community. Community members, they can access a dedicated website through our main SNST website, and also there they will find information and resources in English and Spanish, which are the main languages in our area. Users who are certain years old and over are allowed to register, but even if they decide not to register, still they can access the resources and services from this website. So we are very excited about this. Right now, we are funding this intervention through the CDC Public Health Infrastructure Grant. But we are planning, our intention is to keep this service even beyond the end of that CDC grant in 2 years if we need to. So far we have more than 200-300 people utilizing those services within the first 2-3 weeks of that program. So it's a very exciting intervention. And finally, I want to refer to our mosquito surveillance activities. Actually, this year has been a very active year for mosquito control. And here we have an increase in West Nile virus cases in Clark County. Until last week, we had 24 human cases reported. 11 of them actually required hospitalization because they suffered the most severe form of West Nile, which is the neuroinvasive presentation. so far, no deaths have been reported in our community. I also should say that up to date, 46 sick calls in Clark County have been identified as, having positive mosquitoes infected with West Nile virus. And also in terms of San Luis encephalitis, which is another disease transmitted by mosquitoes, there have been 8 sick calls where we have identified mosquitoes, transmitting this infection. So right now, our environmental health team, our surveillance team, they are partnering with community members and local authorities trying to identify additional ways to address the mosquito control issues and challenge that we are going through. Again, just to bring a context, last year in 2023, we had only 2 cases of West Nile virus, and we didn't have cases the 2 previous years. So this is an increasing problem, and we want to be able to identify resources to address that in the community. So so far today there is not an integrated mosquito control work in Clark County. We were just initiating that discussion with our partners. I will stop here for any question.
Thank you. Are there any questions from board members? Thank you very much, Doctor.
Thank you.
Next up, we have Central Nevada Health District, Dr. Ted McDonald.
Thank you, Mr. Chairman. Dr. Ted McDonald for the record. I have before you my report, and I also have just a few highlights to go over. It's been a busy 3 months in the Central Nevada Health District. Like everyone else, reaching out to the school districts, we've been very successful with efforts for vaccination in the 4 counties and the city of Fallon. We have hired new personnel, primarily in the environmental health and emergency management planning. So we're successful in having 2 new employees, one that I've reported, another new one, Olivia Diaz, Masters of Public Health, who will be our environmental health inspector. We have just finished our Burning Man environmental health process. It was quite an ordeal for a small team. It was 9 days, and the team rotated out in the desert and had a generally benign time. There was a little bit of controversy at the event with the unfortunate demise of one of the participants on the first day, but our services went smoothly. Maria, our environmental health manager, did a great job of supervising and making contact and worked through the initial communications change with the health district taking over from the state. It was a little bit of a challenge to initially, make sure that people understood that the Central Nevada Health District was going to be on site and be there, but it worked out great. And we have learned a lot. We'll be doing a evaluation of this and presenting it to our board in October of what we feel can be done better or different. And we will bring that information to the state board afterwards. We may be looking at changes in structure and fees. The common theme for our epidemiology and our community work this last 3 months has been one of building bridges and cooperation. We've had many opportunities to work with the state agriculture department, with mineral counties, board of directors, and with entities in Churchill County, the Banner Hospital, to develop ways of communication and start to develop a method of being able as a health district to help them facilitate their ability to get labs done efficiently, and also as a follow-up to be able to keep in contact with patients that may be difficult for health authorities to follow or emergency departments to follow. And really, we are very fortunate in Churchill County that we have a mosquito abatement district. So we have been working closely with them in monitoring our West Nile virus. The county has been a good partner in this endeavor, and we get regular reports on the mosquito pools in our areas and in adjacent areas, because as the district kind of touches close to everybody, even Las Vegas, we're interested in where things are happening with these counties. And we have a mechanism for contacting our clinics, our hospitals, and our veterinarian services whenever we have changes. Also, I'd like to give just to wind things up, is to give Dr. Azam a big shout out. I've recently had some questions about congenital syphilis. We have had some potential cases in our counties, and it culminated into an area where I needed some guidance. And yesterday I called Julia Peak. Julia Peak hooked me up with Dr. Azam. He called me probably within a half hour of me contacting Julia. And he spent a half hour with me reviewing the cases that I'm working with, and provided great mentorship, excellent information, and a lot of reassurance. And so I just want to say that in everything that we're doing to start up this new health district, the state of Nevada, public health, and all of our, all the districts have been very helpful and supportive of us. And I really want to say thank you very much for that. And that's pretty much all I've got. So are there any questions?
Thank you. Are there any questions or comments from board members? Well, we thank you too. We appreciate, I know starting this new has been a lot of work. So thank you.
Thank you.
Next up is the state of Nevada, Dr. Azam.
Good morning, Mr. Chairman and esteemed members of the board. Good morning, everybody. For the record, Aizen Azam, State Chief Medical Officer. By the way, can you hear me okay?
Yes, you're coming through clear.
Perfect, thank you. So you already have a copy of my report, so I'm going to highlight the most important points. In the next few minutes or so, we will cover the ongoing mpox epidemic at the Democratic Republic of Congo and Central Africa. We will update you on the highly pathogenic avian influenza national outbreak among dairy farms, and will conclude with some highlights regarding the value of wastewater surveillance. Mpox clade 1 cases are rapidly increasing in Africa. Unlike the previous global outbreak caused by Mpox clade 2, where most cases were among men who had sex with men, this current outbreak in the DRC, or the Democratic Republic of Congo, is caused by Mpox clade 1, where most cases are among women and children. On August 14, the World Health Organization declared that Mpox outbreak in the DRC and some African countries, they declared it as a public health emergency of international concern. It's important to mention that both clades, clade 1 and clade 2 Mpox, are rapidly spreading through sexual transmission, with clade 1 more easily transmitted through routine close contact. According to CDC, the risk for Mpox spreading in the US is low due to a limited number of travelers and direct flights from the DRC and its neighboring countries. However, in mid-August, Sweden confirmed the first clade 1 Mpox case outside the African continent, and a week later, Thailand confirmed the second case. Both cases had recent travel to
We lost you, sir. We'll see here if Dr. Zam gets reconnected in a second.
It's trying to put us back in the meeting.
I don't know when we were cut off.
Dr. Purnell, can you hear us?
Now we can, but there was quite a period of silence.
Okay, great. For the record, I'm just going to note we had some technological difficulties. It looks like we lost connection with the Southern Nevada location. Dr. Azam was in the middle of providing his report, so we are going to resume there.
Okay, so
Thank you.
now a brief update on the highly pathogenic avian influenza. As you know, for decades, the highly pathogenic avian influenza H5N1, the virus, has been circulating and spreading among wild birds, causing outbreaks in poultry and most recently among dairy cows, with several recent human cases among farm workers in the US. So far, 14 human cases have been reported this year in the US. 4 of those were exposed to infected cows and 10 to infected poultry. So far, no H5N1 human cases or cow infections were detected in Nevada. However, it's important to mention that the infectious H5N1 virus was detected in raw milk produced by sick cows. And pasteurization inactivates the virus in the milk and provides strong assurances that the commercial milk supplies are safe. According to CDC, the H5N1 risk to the public in the US continues to be low. However, with the increasing transmission among dairy cows around the nation, the Division of Public and Behavioral Health is urging healthcare providers to consider avian influenza among their patients and to consider that diagnosis and their differential diagnosis among patients with compatible symptoms and those who have recent exposure to farm animals. Currently, several Nevada healthcare providers are participating in our statewide enhanced influenza surveillance. Additionally, the division is urging healthcare providers to ensure early detection, prompt response, and timely reporting of cases to local and state health authorities. We are carefully monitoring the situation and closely collaborating with the national and the state departments of agriculture and with our community providers, local health authorities, the academia, and our state public health lab. Now a brief update on our enhanced wastewater surveillance plans. Nevada and the nation continue to face a severe drug overdose epidemic, with substance abuse and opioid-related death rising to extremely high levels. Challenges in current data collections. Are we okay? Okay. I heard that sound before. So challenges in our current data collections include delayed analysis and interventions, and stigma surrounding drug use is severely hindering the effectiveness of our activities and policies. We certainly need more real-time surveillance tools to identify the presence of such dangerous substances within our communities and to reverse the trends of this deadly epidemic. While providing timely information on drug use, wastewater surveillance can also early detect emerging biological agents and the existence of chemical and physical pathogenic substances, which can cause serious illnesses among humans. Wastewater surveillance can also help us focus our responses specifically to those at highest risk for drug overdose and death. An additional benefit of wastewater surveillance is the ability to respect individual anonymity. With that, I'm concluding my remarks and will be happy to answer your questions. Thank you.
Thank you very much, and apology about the loss of signal in Southern Nevada, but I think we We do have your written report, and we did get most of your MPOCs. It was probably 30 or 40 seconds that we missed. Are there any questions or comments from the board? Thank you, Dr. Zahn.
Thank you.
Next up is Douglas County, Dr. John Holman. We do have a written report. I'm not sure if we have a verbal report. We also have a written report from Lander County. Are there any more verbal reports from other districts? Okay, thank you. That concludes our county and district health reports. Agenda item number 4 is the consent agenda. Are there any items that the board would like to pull from the consent agenda? Is there any public comment on the consent agenda? There's no comment in the south.
There is no comment in the north.
Thank you. I'll call for a motion on the consent agenda.
This is Dr. Morosky. I'll move to approve the consent agenda.
Charles Smith, second.
Been moved and seconded. Discussion? All in favor of approving the consent agenda, please say aye.
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 Opposed, nay. Consent agenda passes as written. Agenda item 5 is discussion and possible approval of variance number 770 regarding requirements of NAC 459.556 C and D, requesting approval to use a portable X-ray machine in lieu of a stationary X-ray machine to provide imaging services for patients at his office, submitted by James Detling, MD. May I call on John Follett, please?
John Follett.
Yes, you're good.
John,
I think it was on before.
what is it?
You go ahead and hit the button again, and that light came on. You're good.
John Follett, Follettee. Hello, Chairperson and members of the board. I'm John Follett from the Radiation Control Program, speaking for variance case 770. Summary of the variance. Variance applicant James Detling, MD, submitted a request for a variance from the requirements of NAC 459.556 C and D on July 22nd, 2024. The applicant is requesting approval to use a portable X-ray machine in lieu of a stationary X-ray machine to provide imaging services for patients at his office located at 801 South Rancho Drive. Intent of the regulation. The intent of NAC 459.556 C and D are to protect the health and safety of patients and radiologic technologists by limiting the use of portable or mobile X-ray machines to situations where patients cannot be transferred to a stationary machine. The reasons for limiting the use of portable or mobile X-ray machines include portable and mobile X-ray machines are intended for bedside use when a patient cannot be transported to a designated imaging room with a permanently installed imaging system. Examples include intensive care, critical care, emergency, and surgical patients. Portable and mobile X-ray machines produce poorer quality images as compared to stationary machines due to several factors, such as the X-ray tube is less stable, inconsistent measurement of the distance and angle between the X-ray tube and the X-ray film, and limited imaging settings. These factors may lead to blurred or poor quality images, which will have to be retaken. Repeat imaging increases the overall radiation exposure to patients. Portable and mobile X-ray machines do not protect technologists from radiation as well as properly installed stationary machines. Degree of risk to public health and safety. The health risk associated with this variance is increased radiation exposure to patients, radiological technologists, and non-radiation workers such as support staff and/or members of the public that may be present during radiographs. Limiting the use of portable X-ray machines to situations where patients cannot be transferred to a stationary machine is consistent with how other states regulate X-ray machines and is supported by a recent position statement issued by the Council of Radiation Control Program Directors. Exceptional and undue hardship. Strict application of NAC 459-556-1C and D will require the applicant to purchase and use a stationary X-ray machine. The circumstances associated with this variance are not unique to the applicant. This is the same financial burden placed on more than 200 similar medical practices and is not considered an exceptional or undue hardship. Impairment to the purpose of the regulation. Approval of this variance will substantially impair the purpose of the regulation. The reasons listed in the variance request could be applied to over 200 other registrants, including 89 physicians and 109 chiropractors. Since there are no unique or exceptional conditions associated with this variance, it would greatly hinder the purpose of the regulations and create an inequity among similar medical practices. If approved, over 200 physicians and chiropractors, as well as 385 small clinics across the state, may also apply for a similar variance, which would further impair the regulation. DPBH staff recommend the State Board of Health deny variance case 770, James Detling, MD's, request for a variance to NAC 459-556-1C and D because the reasons cited in the variance request are not unique to the applicant. The financial cost of compliance with the regulation is the same for over 200 similar medical practices, and it would impair the purpose of the regulation.
Thank you, Mr. Follett. Questions or comments for Mr. Follett from the board member? Is there any public comment on agenda item number 5? There's no public comment in the south.
There's no public comment in the north.
Thank you, Mr. Follett.
Thank you.
Call for a motion on agenda item number 5, variance 770.
This is Dr. Morosky. I'll make a motion to deny the variance as presented.
Charles Smith, second.
Been moved and seconded. Discussion, further discussion. Okay, the motion is to deny. All in favor to deny agenda item 5, please say aye.
Aye.
Aye. Aye.
Oppose? Say nay. Any abstention? Motion carries to deny agenda item number 5. Agenda item number 6, discussion and possible approval of variance number 760 regarding NAC 450B.384, requesting approval to allow paramedics and nurses employed by Rural Medevac Alliance to perform escharotomies. This is submitted by Joy Lohner on behalf of Rural Medevac Alliance. Bobby Sullivan, DPBH, please.
Good morning, Mr. Chairman and members of the board. My name is Bobby Sullivan. I'm the program manager for the EMS program. Before you is the recommendation from EMS staff for the previously mentioned variance request from Joey Lerner, Rural Medevac Alliance. The applicant has submitted a request for variance from the requirement of Nevada Administrative Code 450B.384, requesting approval to allow paramedics and nurses employed by the applicant to perform escherotomy. Performing an escherotomy at the paramedic level is not recognized by the National Highway Traffic Safety Administration for pre-hospital care. After review of the request, it's been determined that there is a degree of risk to public health or safety, as performing the procedure under sterile conditions in the pre-hospital setting is unlikely and could cause delay of care and transport of the critically ill patient. Again, after review, staff have determined the applicant has not demonstrated an exceptional and undue hardship. DPBH staff recommend the State Board of Health deny case number 760 Joey Lerner, Rural Medevac Alliance variance to Administrative Code NAC 450B.384. This recommendation only addresses paramedic personnel, not advanced practice nurses as cited in the application. Staff have been unsuccessful in finding industry support for pre-hospital escherotomy by paramedics. Reference listed by the applicant in the request for variance caution performing escherotomy at the bedside in an emergency department and strongly recommend the skill be performed in a surgical suite. I'm happy to answer any questions.
Thank you. Are there any questions from our board members? Thank you, Ms. Sullivan. Is there any public comment on agenda item 6?
We have no public comment in the north.
No public comment in the south. Call for a motion then on variance number 760.
Charles Smith, I make a motion to deny the variance number 760 as submitted.
Mr. Cartwright, second.
Been moved and seconded. Further discussion from the board? All in favor, you're voting to deny, say aye.
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 Any opposed, say nay. Any abstention? Okay, action item 6 is denied. Next up is action item 7, consideration and possible adoption of proposed regulation amendments of Chapter 449 of the Nevada Administrative Code, LCB file number R004-24RP1 that revises LCB file R016-20AP relating to cultural competency training for employees of healthcare facilities by establishing new standards in accordance with AB 267 of the 2023 legislative session. Mr. Paul Schubert, please.
Good morning, Chairman Pennell and members of the board. For the record, my name is Paul Schubert, S-H-U-B-E-R-T. I'm Chief of the Bureau of Healthcare Quality and Compliance.
Can you hear up in the north?
Yes, we can.
I think you're.
I'll continue.
Sorry.
I'm presenting for your consideration proposed regulations, LCB file number R004-24 with errata regarding cultural competency training for employees of licensed healthcare facilities. The proposed regulations were processed in accordance with NRS and NAC Chapter 233B, Nevada's Administrative Procedure Act. The proposed regulations were drafted to align Nevada Administrative Code, Chapter 449, with the changes made to Nevada Revised Statutes, Chapter 449.103, with the passage of AB 267 during the 2023 legislative session. In addition, the proposed regulations address issues identified since the initial adoption of cultural competency regulations, such as it was determined unnecessary for facilities to provide the agency with a particular training program being used by the facility. Also, the proposed regulations were modified to streamline the approval process. Lastly, the proposed regulations reduce burdens on licensed healthcare facilities by establishing minimal standards. AB 267 clarified which employees must receive training through cultural competency courses approved by the department and exempted employees whose license, certification, or registration requires a course in cultural competency as part of the continuing education requirements for renewal of their professional license, certification, or registration. The exemption language doesn't limit the exemption to any specific profession. Rather, it speaks to any professional license, certification, or registration. Thus, layperson caregivers are the targeted recipients for cultural competency courses approved by the department in accordance with these regulations. In addition, AB 267 made statutory changes to ensure timely review of courses submitted by licensed facilities. The state agency conducting reviews on behalf of the department must approve or deny approval of programs of instruction submitted not later than 10 days after receipt of the application. These regulations set parameters for this to occur. Finally, AB 267 adjusted the minimum hours of cultural competency continuing education requirements for several professions. The agency conducted a small business impact study and generated a summary statement that concluded the implementation of the proposed amendments should result in a decrease in cost to small businesses. Although AB 267 changed responsibilities for the department and training approval or rejection timelines, the statutory requirements and intent of the mandatory training remain substantially unchanged. Hence, the agency is limited in its ability to further reduce costs of this training to small businesses. However, the proposed improvements associated with these regulations may create potential for increased reduction in cost for those facilities that generate and submit facility-specific programs. A public workshop was held on November 14th, 2023. Recommendations received during the workshop included the following, and there's quite a few. The proposed regulations should not require cultural competency training to be repeated. There was support for the number of training hours and periodicity established in the draft regulations. There was recommendation for the number of hours spent in CCT, cultural competency training, to count towards requirements for employees training found elsewhere within specific facility type regulations. There's recommendation for the number of training hours to be adjusted to 45 minutes to 1 hour. There's recommendation to expand the time from hire to receipt of the training from 90 days to 180 days. Recommendation for streamlining the course approval process and for continuing approval of already approved courses. Recommendation for cultural competency training to be an annual requirement of not more than 2 hours per year. Recommendation to allow training certificates to be represented electronically in a facility's personnel training management system. Recommendation for courses that don't receive approval to require the agency to identify any deficiencies identified along with the denial. Instructor qualification should not require years of experience in providing cultural competency training. Recommendation for courses to be provided in a modular format. Recommendation for the state to produce free training and make it available online, much like the elder abuse training established by the Aging and Disability Services Division. Recommendation for the level of training to be geared towards the level of education of the individuals receiving the training. Just 4 more. Recommendation for the training not to exceed 2 hours, recommendation for 2 hours of training every other year, and recommendation for the certificates of training to be transferable from facility to facility, and finally, recommendation for 45-minute courses annually. So, we incorporated several of these recommendations into the proposed regulations, but had to make some difficult decisions about required hours of instruction and periodicity of the training. We attempted to strike a balance that acknowledged the recommendations for reduced hours of training, yet still minimally required enough instruction time to effectively cover all of the statutory topics. In the end, we landed on at least 2 hours of instruction. The at least phrase allows the course providers to adjust their instruction to a longer length if necessary, whereas 2 hours is more than several workshop attendees recommended, yet far less than some currently approved courses. The proposed errata includes only one adjustment at Section 13. This adjustment is to ensure that all of the statutory requirements are part of the instruction. Specifically, Section 13, sub 1, sub C removes, quote, one or more of, end quote, from the sentence, so it should read, quote, a course or program on cultural competency training must include without limitation the following course materials: instruction on preferred approaches to providing care for people who fall within the categories in paragraphs A to F, inclusive of subsection 1 of NRS 449.103, end quote. Chairman and members of the board, you'll no doubt hear persuasive testimony for additional changes to these regulations. You may also hear arguments indicating that these regulations don't follow the letter of the law and tend to undermine the laws. I submit to you that we have made reasonable adjustments in these proposed regulations, and our intent has always been and remains to follow the Nevada statutes and their intent. These training regulations are only one aspect of the laws that provide protections to patients receiving services from licensed healthcare facilities. These proposed regulations do comply with the intent of NRS 449.103 as modified by AB 267, and in fact reference this statute in several sections to ensure compliance by training programs with the specific sections of the law. In the packets that were provided prior to the hearing that was scheduled for June 7th meeting, there were written comments from Healthcare Services Group, Inc., representing workers in several different facilities in Nevada. Healthcare Services Group indicated they applaud our reduction in the number of hours of required training in proposed regulations, but also argue that the intent of NRS 449.103 can be reasonably achieved through less frequent applications of the training. This group has a desire to lessen the frequency of the training from once every 2 years to once every 4 years. In addition, this group believes the duration of the training should be reduced from 2 hours to 1 hour. Also in the June 7 packets, there were written comments from Dignity Health, representing several hospitals in Nevada. Dignity Health explains that they have an already approved course that is approximately 90 minutes in length for the initial training of employees, and they provided a sample errata for your review that would remove the 2-hour requirement for the initial training, but would retain the 2-hour requirement for subsequent trainings. During the June 7th meeting, Allison Ginkgo, representing Dignity Health, provided public comment about the errata. They would like considered to change the initial training requirements due to the already approved program they have providing to employees that is approximately 90 minutes. I want to clarify here that all of the currently approved programs will remain approved for the next 3 years after passage of these regulations in accordance with Section 14, subparagraph 6. We will reset those approval dates. This recognizes the efforts and the work that was done by all of those applicants during COVID and up to this point where we have approved those programs. And we feel like those programs were well vetted and actually accomplished the intent of the statutory requirements. And therefore, we want to go ahead and recognize those approvals and continue those approvals for the next 3 years in accordance with subsection 14.6 of these regulations. Also in June 7 packets, there were written comments from High Sierra Area Health Education Center, AHEC. AHEC didn't address any changes for the regulations, but does speak to the necessity of training. And at the same time, they acknowledge the challenges with costs and time commitments for facilities and practitioners. AHEC goes on to explain ways in which they have made the training more affordable by tailoring training to accommodate different groups. During the June 7 meeting, an AHEC representative provided public comment regarding concerns that the minimum hours of instruction may not allow sufficient time to ensure all items are covered. Also during the June 7 meeting, Jesse Wadhams provided public comment on behalf of the Nevada Hospital Association regarding concerns at section 12.3 needing more clarity. This is the section which addresses identification by an applicant that their program is either a third-party program that would be available to any individual in any facility, or if it's a facility-specific program that is designed specifically for a certain type of facility. Section 14.2, Mr. Wadhams indicated that the may should be must. This is at the time of admission. That section speaks at the time of admission of approval of a program. I'm sorry, at the time of submission, approval of the program. I believe we want to retain the may there for disapproval of certain programs. Section 14.6, the 3-year window for already approved programs should be extended. And as I just indicated, we will administratively continue the approval of those programs for the next 3 years. Lastly, there was an inclusion in the June 7 packets regarding written comments from Mr. Cafferata. Mr. Cafferata has developed approved cultural competency training courses. In Mr. Cafferata's comments, there's indication that the proposed modifications to the regulations do not fully address the language in NRS 449.103. Mr. Cafferata indicated the proposed regulations allow any course approved by a licensing board to be approved by the state without further review for licensed healthcare facilities. It should be noted that the regulations don't provide this allowance. Rather, it's the statutory changes in AB 267 that provide an exemption for licensed individuals. Mr. Cafferata goes on to provide several examples of areas within the proposed regulations that he believes diminishes consumer protections and allows for continued healthcare delivery disparities. Mr. Cafferata urges the board to require the agency to review these regulations with a patient-centered approach to regulating healthcare. The agency provides the following additional information for consideration. In addition to these regulatory training requirements, we enforce 3 other statutes under the heading Standards and Policies for Treatment. Those are NRS 449.101, which prohibits discrimination, NRS 449.102, that contains privacy protections, and NRS 449.104 that requires patients to be identified by their gender identity or expression. So even in the absence of training, there are laws designed to assure these protections. The training requirements, both in statute and these proposed regulations, at their core are intended to change poor behaviors in persons delivering healthcare services, but enforcement is a measure of whether, in a particular circumstance, the individual receiving the services was treated with respect and dignity. It's not my intent to put words in the mouth of any of these organizations or individuals, or to diminish their written testimony, and I anticipate them providing oral testimony as well. But I do want the board to know the agency has attempted to find a balance with these regulations. Therefore, staff recommends the State Board of Health adopt the proposed regulation amendments to Nevada Administrative Code Chapter 449 LCB file R004-24 with the proposed errata to Section 13. This concludes my remarks, but I remain at your service to answer any questions.
Questions from our board members for Mr. Schubert? Hearing none, thank you.
Thank you.
We'll open up for public comment. Any public comment concerning agenda item number 7? And please state your name, spell your last name, and your testimony will be limited to 3 minutes. Thank you. Please come forward if you have public testimony.
Good morning. For the record, my name is Jesse Wadhams, Wadhams, with the Nevada Hospital Association today. First, I do want to thank Mr. Schubert and his team. They've been very thorough on their regulations. His presentation was a very thorough review of the whole process, which has been an extended one, I think, at this point, to be sure. That said, I do want to reiterate a couple of comments and maybe thankfully, Mr. Schubert sort of preface them for me. The Nevada Hospital Association continues to reiterate the concept that Section 14.2 with the may approve a compliant course is unnecessary, and I think it sort of continues the underlying necessity of AB 267, which was intended to create a more streamlined process. At its core, I think a compliant program, if it meets the requirements of the statute and the regulation, what discretion is necessary in that state, it should be approved. In fact, if you look at AB 267, Section 1.5 particularly, you see that part of the concept of AB 267 was intended to create a library of courses available across all facilities. So we would continue to reiterate that, you know, a compliant course should be approved and should be approved expeditiously. Again, we kind of touched on Section 1213. Part of the concept is, again, building that library, having facilities or other entities within an entire organization structure, a corporate chain. They should be available to use a particular course. And just to use an example, a course approved at Renown could be used at UMC. That's part of the intent of Section 1.5 of AB 267, is building that library. And I think the idea of a 3-year approval requirement, Section 14.6, it seems arbitrary, quite frankly. It's not in statute. If there's no change in the law, why would we need to reapprove a course that is been working, is valid? Either a longer term for review, or we would recommend actually re-review on changes in the law or regulation. A course should be reevaluated. Those are our comments. Again, I don't think these are massive issues. I don't want to extend the process of the regulatory workshops, but I do think it's potential to have a couple more of these conversations. And then I would be remiss if I didn't put on the record that the Nevada Hospital Association supports the comments of dignity that will be made next. Thank you.
Thank you, Mr. Wadhams. Next comment in the north. We'll let the north go on. We do have a comment in the south. We'll go ahead with that next. Please state your name and spell your last name, please.
Good morning, Honorable Chair, honorable members of the board, and everybody present here. My name is Ron Sumbang.
You push that button. That mic is catching you. It's not this one. You push your button. Okay.
Yeah,
Okay. I am the current chairman of.
I'm sorry, your name again?
Oh, I'm sorry. My name is Ron Sumbang, Sumbang, Sumbang.
Thank you.
I am the current chairman of ECHO, ECHO, the largest organization of care home owners, normally called as group homes, but we care. Of 10 beds and below. We also have under us the HERCs, the Home for Individual Residential Care, and the CBLAs, Community-Based Living Arrangements. In our industry, we mostly take care of the elderly or older persons as defined under NRS 200-9052, subsection 6, which means a person who is 60 or over. That would make the youngest to be born in 1964. A totally different generation. No cell phones, laptops, YouTube, Twitter, TikTok, and many other things that we have come to embrace today. During our time, date means physically going out and spending time. Nowadays, date can be via online and breakup could be through text. Legislative Council Digest states existing law prohibits medical facilities, facilities for the dependent, and certain other licensed health facilities and other employee or independent contractors of such a facility from discriminating in the admission of or the provision of services to a patient or resident based on wholly or partially on the actual or perceived race, color, religion, national origin, ancestry, age, gender, physical or mental disability, sexual orientation, gender and identity or expression, or human immunodeficiency virus status of the patient or resident or any person with whom the patient or resident associates. Well, we can all agree on the well-meaning intent and purpose of the training. But the application to a care home facility, the reality of said application, and the unintended consequences needs to be considered as well. Each care home facility is mandated as a part of the admission process to conduct an interview, using an admission form mandated to reflect the preferred pronouns, genders, sexual orientations, and bodily alterations. By asking all these questions to reflect the information in the admission form as required for compliance is kind of contradictory to the well-meaning intent and purpose of being culturally sensitive. Example.
Kelly
go ahead and give
Knutson,
you
for the
thir-
record, your time
ahead.
is up. If you could please wrap up.
I'll go ahead and give you, I'm sorry, I'll give you 30 more seconds since we had a little microphone problem, but 30 more seconds, sir.
Sorry. Example. Asking a 70 or 80-year-old female who is devout religious person, what pronouns would you prefer for us to address you? He, she, him, or her, or it? May we know your gender preference, man, woman, gender queer, or gender fluid? If you don't mind us asking, are you straight, gay, heterosexual, or bisexual? Did you ever had any gender affirming surgery? There were already many instances where the staff were berated for being insensitive for asking such question. Again, a contradiction to well-meaning intent and purpose of being culturally sensitive.
Now we do have to have you wrap it up. Thank you very much.
Thank you very much.
Chair Pinnell, we have public comment in the north, and it looks like we also have public comment online.
Okay, we'll hold up on public comment in the south until we take care of the north and online.
Good morning, Chair and members of the board. My name is Allison Genko. Last name is spelled Genco, and I'm the Director of Government Relations for Dignity Health St. Rose Dominican. On behalf of St. Rose and our 7 acute care hospitals in Southern Nevada, thank you for the opportunity to submit additional comments regarding the division's proposed revisions to regulations for cultural competency training. We also want to sincerely thank Chief Schubert and his staff for working with us on our concerns. St. Rose currently operates a self-developed training program, which has been approved based on its comprehensive coverage of all required elements within a 90-minute time frame. This program has been meticulously designed to meet the needs of our employees while ensuring compliance with all necessary standards for cultural competency education. However, R004-24 RP1 as currently drafted would require St. Rose to undergo the development and implementation of an additional training program for newly hired employees because of the 2-hour requirement in Section 11 of the regulation. While we acknowledge the importance of thorough training for all staff members, we believe that our currently approved 90-minute program encompasses all essential content and should not be deemed insufficient simply because it is delivered in less than 2 hours. It is crucial to note that St. Rose already provides our approved 90-minute course to all employees, underscoring our commitment to ensuring a knowledgeable, capable, and culturally competent workforce. Implementing additional training time to meet the 2-hour threshold would not only create a significant financial burden on the system, but also introduce unnecessary administrative complexities leading to even more financial burden. As previously mentioned, St. Rose submitted a proposed amendment to Section 11 for the June board meeting, as well as this meeting. The amendment would strike the words 2 hours in Section 11, subsection 1, and instead add the words 2 hours into Section 11, subsection 1B, thus applying the minimum hours requirement only to biennial ongoing training for employees. Therefore, request that the board delay action on this regulation and conduct an additional workshop with stakeholders to work through these issues. Alternatively, if the board decides to adopt the regulation today, we would ask that the board make a motion to adopt the regulation with St. Rose's proposed amendment. Adopting the regulation without the proposed amendment would cause a significant fiscal and administrative burden on St. Rose. Thank you for your time, and I'm happy to answer any questions the board may have.
Thank you, Ms. Janko. There's more comment up north first, and then we'll take you, okay? I'm sorry. Go ahead with public comment up north and then online.
Good morning. My name is Jake Afreda, and I represent ASL Training, which is a third-party provider for cultural competency training. I have submitted my written testimony, but I would just like to highlight a few points here. And thank you, Mr. Schubert, for encapsulating my submissions from the June meeting. I would like to point out that the proposed regulations have now stripped out section number 9, which is the elimination of the location of public notice of where to file a complaint. This allows the posting to not be readily available to the public in common areas, and this creates an unnecessary barrier for people who want to file complaints with the state. I don't want to rehash a lot of the points that have already been made, but I would like to really focus on section 16, which is transitionary language, which has the full force of law, but is not codified in the NAC. And it allows courses that were created in 2021 to remain approved until 3 years after these regulations are approved by the Legislative Commission filed with the Secretary of State. Because this is not up for review as part of the regulations, but rather is accommodating the industry request to provide outdated and obsolete material, the point is clear that the industry is of higher priority than accurate and up-to-date information impacting direct-to-patient care. It was included as part of the discussion during public workshop. However, it has now been moved to this area where no comments or input contradicting the importance of this language is relevant. The state received feedback about this one element from more than just the industry, but the feedback from the third-party providers was to require new content to be provided within a 3-year period. The report made by DPPH tells you no adverse impacts were reported. And I have testified in a number of meetings and public testimony that these regulations create many adverse effects to the number of patients, their associates, and families. Again, these regulations have stripped out the fundamental context of healthcare disparities, the social determinants of health. And this undermines the basic understanding of why Nevada has passed a law to protect marginalized patients, their families, and associates. In conclusion, the new proposed regulations prioritize the industry over the patient. The language continues to be confusing and deferential to the requests of the industry, not to the benefit of patients, or reflecting the input of patient advocates. I would also like to say that if Dominican St. Rose can provide this content in 90 minutes, and I've been required to provide it in 9 hours, I think that there's really disparate treatment in terms of what trainings are approved and which are not. I did have to go through the same approval process. My trainings were rejected at first as well, and I was told that I had to include more content. At this point, this puts me at a significant disadvantage in providing this training. Again, if people have to spend 9 hours and pay their employees 9 hours of time plus for the training, and St. Rose can do it in 90 minutes, I'd like to see their training because obviously I'm way off base. So again, thank you for the opportunity to provide my comments, and I appreciate your time. Thank you.
Thank you. Will you spell your last name for me, please?
Certainly. My last name is Cafrota, spelled C-A, F as in Frank, F as in Frank, E-R-A-T-A. Thank you.
Thank you.
Good morning, board. My name is Ricardo Rubalcaba Paredes. First name spelled R-I-C-A-R-D-O. Last name Rubalcaba spelled R-U-B-A-L-C-A-B-A. Second last name spelled P as in purple, A-R-E, D as in dog, E-S. And today I represent High Sierra Area Health Education Center, the broader Nevada AHEC network, and the 40+ years of work the Nevada AHEC program has done to drive lasting change to advance health equity across Nevada through recruitment, training, and placing diverse healthcare professionals into rural and underserved communities to improve access to quality care. AHEC's commitment to health equity and cultural competency is unwavering. We have worked with legislators like Senator Spearman to support NRS 449, and in 2021, we launched our cultural competency training program, Nevada Cultural Competency, in partnership with the Nevada Primary Care Association to continue promoting equity and culturally responsive healthcare practices to meet the needs of Nevada's diverse patient population. As it relates to agenda item number 7, AHAG would like to make clear that we believe that it is viable and essential to maintain comprehensive training that incorporates the current competency areas. AHAG is conscious of the critiques and concerns of practitioners, lawmakers, and facilities regarding the cost and the time commitment required to complete the mandatory training. As a result, High Sierra AHAG has actively tried to maintain the integrity of the law and meet the needs of those mandated to take the training by adapting pay structures and working to diversify our training modalities to meet the needs of organizations and providers. For example, we developed the Train the Trainer program, which is a cost-effective alternative to our open enrollment option, in which health facilities can license our copyrighted materials annually and receive direct training from our staff, allowing them to complete and maintain required cultural competency training within their organization. We also developed a self-paced cultural competency training, which is an asynchronous, self-driven alternative that offers facilities the flexibility they need to implement the training. Recently, AHAG has had the opportunity to work with many non-mandated and community-based organizations, and regardless of the ruling, AHAG will continue to promote and expand on equity, compassion, and inclusivity across sectors by equipping public health professionals and other professionals with education and the tools for culturally aware practices, ensuring equitable care for all Nevadans. We invite you to join us in expanding your understanding of health equity to also include notions of challenging systemic oppression in daily practices and policies. If you're interested in the work that we are doing at AHEC, please feel free to contact us at info@nevadaculturalcompetency.com. I would also like to mention that I have also submitted a written statement. Thank you.
Thank you.
We have no more comments in the north, but I do believe we have comments online.
Okay, go ahead and proceed with online, please.
Hi, good morning. My name is Blaine Osborne, and I am the president of Nevada Rural Hospital Partners. I'd just like to very quickly echo the comments of the Nevada Hospital Association and those of Dignity Health, and I appreciate your time this morning. Thank you.
Thank you, Mr. Osborne.
It looks like we have one more online comment. Jessica, if you wanted to unmute yourself.
Good morning. My name is Jessica Munger, last name Munger. I'm a community member as well as program manager for Silver State Equality, Nevada's statewide LGBTQ+ civil rights organization. Today, I encourage the board to consider that there is negative impact on the public when you decrease cultural competency requirements, trainings, accountability, documentation, and access. Lack of access to healthcare is a problem for many people across our state for various reasons, and it's a profound problem with even more barriers for LGBTQ+ folks, particularly gender expansive and trans populations. In my role serving these populations, I have heard over and again how many choose not to seek healthcare because of the way they are treated, misunderstood, ignored, or plainly discriminated against in Nevada healthcare. It is a threat to public health to decrease cultural competency trainings and accountability measures because it directly means fewer LGBTQ+ people are accessing care that they desperately need. Health disparities experienced by LGBTQ+ individuals have been partially attributed to health professionals' lack of cultural competency to work with them. With minimum standards comes minimum competency. Let's be clear, based on the work I do, as well as my own personal experience with incompetency by healthcare providers on LGBTQ+ issues, these adjustments will directly make providers less competent and result in fewer marginalized people accessing healthcare. I hear industry telling you that asking elders about their gender identity is wrong, but our queer elders would tell you that it's life-saving. Just because you may not have experiences that relate to these trainings does not mean that patients don't. And based on comments I've heard so far today, these trainings are severely needed. Despite somewhat improved social attitudes towards LGBTQ+ people over the last several decades, health disparities that adversely affect our community persist. I'm not sure why people who are not part of the underserved communities are telling you that they don't need as much time to understand those communities, but LGBTQ+ individuals' healthcare avoidance and distrust of health professionals is often due to previous or anticipated stigmatization or discrimination during encounters. These disparities associated with social and structural inequalities have a direct impact on LGBTQ+ clients' negative health outcomes, including sexual and reproductive health, mental health, cardiovascular, and cancer-related outcomes. Some people are talking about cost-saving measures. I am talking about life-saving measures. None of us know what we don't know. And what we may feel is a small adjustment to regulations to decrease the demands on providers is a major and systemic problem for protected classes within our state. I encourage you to retain and increase cultural competency training standards and understand the severity of the situation our LGBTQ+ Nevadans are in when providers are ill-equipped to care for them, and they are ill-equipped to report when they've experienced harm. Thank you.
Thank you, Ms. Munger. If that concludes online comment and comment in the north, we'll go ahead and open comment for Southern Nevada. Please come forward.
Good morning, sir. Good morning, Mom. My name is Dorothy Domingo, residential care facilities with multiple facilities in Nevada. Under training, I sincerely hope that this honorable body consider the different types of providers who were affected, the level of education of the staff, and the way the training can be taken. Many of the current training agencies approved by the state are online courses. Many of the topics discussed and verbiage used are either very clinical or medical. Many of our staff in our specific industry are mostly in their late 50s and up. With great respect to them, despite being able to speak, read, and write English, most of it, not all of their education level, not rise to the level of the current cultural competency training. Most, if not, all are not tech savvy, hence does not know how to do online trainings. We are currently in the top of being overregulated with the most training requirements in the industry. But are we the best because of this? No. We rank at the bottom because where there is no balance. For every training, whether 2 hours, 8 hours, 15 hours, or 16 hours that a staff takes, that is one body taken away from the care of the most vulnerable. Right now, we have a caregiver crisis nationally within the state. We are so overregulated that many investors would rather invest in other states. Hence, despite of our rapid population growth, the number of care homes remains the same since early 2000. Most investors stated that this is not about trying to avoid compliance or less compliance, but rather about sensible and reasonable compliance. I sincerely hope that this honorable board would consider that what looks good on paper, that does not mean it provides the best care for our most vulnerable in reality. Thank you very much for giving me the privilege to speak. Thank you, sir.
Thank you. Will you spell your last name for me, please?
My name is Dorothy Domingo, Domingo. Thank you.
Further public comment?
We have no further public comment in the north or online.
You have one coming forward right now in the south. Please state your name and spell your last name, sir. Thank you.
First of all, good morning to everybody that's here. For the honorable members of the board and distinguished Deputy Chief of the Bureau, Mr. Schubert. I will not take too much of your time. I will just speak based on my experience. We are a small business owner and operator of a group home, which is Alzheimer's. And based on our experience, we operated since 2010 and have not encountered someone who complained to us about being discriminated because of their, pronouns and everything. Recently, we got a survey about cultural competency. All of my staff were trained, but we were cited for not doing it annually. Last year, they were trained. Surveyor said that, it's good that it's not implemented annually, But to my surprise, when I got the SOD this year, that we got cited for all the caregivers. And also, we had experiences also with our elderly people with Alzheimer's that we're providing care for. If you ask them those questions, they would look at you like a deer in the headlights. They wouldn't even know that. One incident got upset. What you see is what you get. Why are you asking me that question? So more so, the staff encountered being insensitive or came out as insensitive by asking those questions. If we're really sensitive enough to consider person-centered, we should look at the background of the person and be appropriate and be sensitive. Respect goes overboard. Everyone you meet, you should respect. And like I said, I have never encountered any incident where someone complained to us that they're being disrespected because of their gender or pronouns and those ideas. More so, we encounter inappropriate questions by our caregiver because of that. And our facility is welcome to everyone. And we are not discriminating on across the board with everything. And with that, I close my comments and thank you all for conducting this meeting. And God bless you all.
Thank you.
Thank you so much.
Thank you, sir. Will you spell your name, please?
Yeah. My last name is Albeza Albeza, and my first name is Felipe.
Thank you.
I appreciate you, sir.
Thank you.
Yep.
Is there any further comment in Southern Nevada? Go ahead and close public comment. Appreciate everybody's thoughtful comments on agenda item number 7. Chair will go ahead and ask for a motion, please.
Chair Pennell, it's Dr. Morosky. I'd like to ask a question of Mr. Schubert, if that would be okay.
That would be okay.
Mr. Schubert, just as in listening to the public comment, question arose. What was the justification for the 3-year approval process? So why pick 3 years to reapprove the content? And then the second follow-up question to that was, just to get clarity, currently existing approved content would be reclocked to now and would then meet the requirement. If you gave a content that was already approved to a new employee who was hired after we enacted this, that would meet the requirement for now. They would not be in non-compliance going forward until that 3-year period was up. So just those 2 questions. Thank you.
Thank you. Again, Paul Schubert for the record. Yes, the 3-year requirement was arbitrary and as described. However, we felt like that was an amount of time wherein things change within our environment or our culture so that we would at least recognize those changes within that 3-year period. So it is truly an arbitrary time frame. It's what we set as, I guess, our maximum for allowing approval of a program. Then your second question about reclocking, yes, that is our intent. We truly believe that the programs that have been approved, again, were well vetted and meet the statutory intent and with regards to content. And so we want to make sure that we recognize the efforts that were made by those applicants that got those programs approved and continue that approval for the next 3-year period.
Thank you.
Any further questions for Mr. Schubert before we go to the motion?
Mr. Cartwright, for the record, Mr. Schubert, if I'm understanding this correctly, St. Rose is saying that their program was approved. You found it to be to meet the requirements of the purpose and the intent of the legislation, why then would we require them to add, if I'm understanding this correctly, why then would we add 30 minutes to that already approved? I mean, I think we all acknowledge that this training is important. Why the extra 30 minutes?
Understood. For the record, again, Paul Schubert. What we looked at was the timeframes that were suggested during public comment, I'm sorry, not public comment, the public workshop. And we were trying to strike a balance that would work with regards to ensuring that there was sufficient time to cover all of the topics. We recognized that the 90-minute program did cover all of the topics and did sufficiently discuss the intent of the statutes. So while this one program actually met that requirement in 90 minutes, we kind of felt like the timing should be set at 2 hours rather than 90 minutes. Again, an arbitrary decision on our part, but I feel like it was a decision that we made to balance balance the information that we received about the regulations.
Thank you.
Thank you.
There are no further questions. I'll call for the motion, please, on agenda item 7.
So, Mr. Cartwright, for the record, I move to approve the adoption of proposed regulation amendments of Chapter 7449 of, we know what we're talking about, with the proposed changes by St. Rose to Section 11 of R004-24 RP1.
Okay, you're recommending approval with the amendment that St. Rose put forward?
Correct.
Okay.
It's Dr. Morosky. I just need to get a clarification from Mr. Schubert because the two answers we got from the question I think are driving this conversation. If we looked at a post-approval of this this action item as initially proposed without St. Rose's errata, would St. Rose be okay continuing to deliver that training for the next 3 years until it was approved, or would they have to go in and add content for 30 more minutes? I think that's where this gets into what are we doing to recognize the work that was done before as we transition into something that's more long-term.
Chairman, if I may.
Yes, please.
Again, for the record, Paul Schubert. Yes, again, in resetting the clock, we would allow that already approved training program by St. Rose to continue and to be in compliance. However, after that 3 years, they would have to comply with the two-hour requirement. What I did want to mention, if I may, Chairman,
please,
is in addition to it's fine if we want to modify the requirements based on the St. Rose errata, but there is also errata that the agency generated, and I'm just hoping to bring that to light as well. So if you want to adopt both or neither, that's fine, but I just wanted to, make sure that there's recognition that there's a small errata that was actually proposed by the agency.
Okay, thank you. I'm going to call a 5-minute recess and confer with the Deputy Attorney General during that time. So we have 5 minutes. We'll come back and reconvene at 1:45. Thank you. Yep. Okay, me too.
If it wasn't, I'd lean it in. finish off. Part of it's out of your control. Yeah.
Dr. Pennell, we show you guys are muted. Can you hear us in the South? We cannot hear you.
Carson City in Southern Nevada, can you hear us?
Yes, we can hear you now.
So
Okay, so for purposes of a record, this is Piran Takis, Deputy Attorney General. The recess was ended in the South, but we have concluded that they were muted. So for online and in Carson City, we are going to effectively start over. And I'll ask Kelly to recall, do a roll call so we can establish that we have regained quorum, and then we will go from there.
Dr. Pennell,
present.
Dr. Murawski,
Present.
Mr. Smith,
Present.
and Mr. Cartwright.
Present.
We have quorum.
Okay, thank you. So apologize for that. I did call the meeting back to order, but it was only in the South and so we had a difficulty with that. So I will go ahead and make sure the meeting's called back to order at this time. And what I did when I started was we had a motion on the table to adopt agenda item 7 with the amendment from Dignity Health. And I called for a second. Is there a second for the motion? Hearing no second, the motion as it was stated dies. And now I would like to call on Mr. Schubert to explain the two erratas that he mentioned, the one from Dignity Health and also the division errata.
Correct. For the record, again, Paul Schubert. The errata from Dignity Health, as I understand it, removes the requirement for the initial training with regards to how long the training should be. In other words, it was 2 hours there and it's 2 hours for the biennial training. So adoption of that errata would allow them to continue their already approved program that is 90 minutes that meets the requirements. So that's their errata. And then, of course, the errata that the division has presented is section 13, wherein we're removing some language that says one of or each of and instead requiring that all of the statutory requirements within the law are part of the training, just to make sure that we are that all of the programs we approve are in compliance with the law.
And then for clarification, I'll call on Mr. Cartwright to repeat your questions to Mr. Schubert, if you would, please, sir.
Thank you, Mr. Chair. Mr. Cartwright, for the record, Mr. Schubert, I guess I'll ask you the question again. If the approved program by St. Rose meets all of the requirements of the statute, and it appears that as I read through the impact statements, I find them compelling. This is obviously complex, but it seems that most who are opposed are in agreement with the proposed changes of St. Rose. I would ask, why are we adding arbitrary time limits to a program that has already been deemed to meet the statutory requirements?
And again, for the record, Paul Schubert, it is an arbitrary time frame that we attempted to establish as a minimum, which, as sometimes we know, becomes the maximum. But we attempted to establish that based on language from the statutes, which established timeframes for professional licensees. So our intent was to have a specific time frame, but it was an arbitrary time frame that certainly we recognize the courses can be conducted in a lesser time frame that and still meet all of the requirements, such as the course from Dignity.
Okay, I'll open it to other board members if you have questions or comments to Mr. Schubert.
Dr. Moravsky, just a question. So I'm getting a little confused in the differences. So if we are saying that a training already approved would be granted the 3-year period to continue to be used, in theory, Dignity would just have to continue, or any institution that already has an approved training would, for the next 3 years, just have to continue to give that training to their employees to meet would they meet the requirement by doing that? And then in 3 years, when they submit, would make the changes and shift necessary, or would this require that they have an approved training but give it over an extra 30 minutes? I'm trying to understand what the difference is for this initial switch, because we have pre-approved trainings already.
Again, for the record, Paul Schubert, and I'm not sure that I can completely address the question, but yes, we are resetting the clock and wanting to continue approval of the programs that are currently approved for the next 3 years. So Dignity could continue to provide that training both for initial employees as well as however they would have to meet the new requirement for retraining, which would be the biennial requirement of 2 hours. So it may be better to adopt the amendment, then it clears from Dignity, because then it clears up that quandary where we're accepting an already approved program for the next 3 years versus any new program coming in would have to meet the 2-hour requirement for initial training. So I guess you could go either way, but it may be cleaner. And maybe this is one for Ms. Takas to provide guidance on with regards to what would be better for ensuring that going forward, the language is clear and facilities as well as the division can ensure compliance.
Ms. Takas?
This is Piran Takis for the record. So if I understand the question that's being asked of me is what the effect of compliance would be depending on if the St. Rose errata is adopted or not. And from what I understand of Dr. Morosky's question is if that time limit that is proposed in St. Rose's errata is, no, excuse me, let me restate. So if the time limit is removed, then they're in compliance. If it stays in, they will need to come into compliance over the course of the next 3 years. So that means that they're not going to be out of compliance initially, but they'll have 3 years to come into that compliance to update their presentation. I don't know if that answers the question that Mr. Schubert was proposing or Dr. Morosky's question.
Again, for the record, Paul Schubert, I truthfully, I believe it could go either way. I think it may be clearer to actually adopt the errata from St. Rose, which would ensure that they're in compliance and that other facilities, when they generate programs and present them to us, that they will be in compliance, regardless of the initial time frame for the initial training. Again, set at an arbitrary time frame, but then for the subsequent training, retain the 2-hour minimum, and that may be the better way to approach this.
Dr. Morosky, any thoughts or questions?
Dr. Morosky, I think this clarifies, and I agree with Mr. Schubert. I think that it may be clearer to the institutions and entities that are working to meet this requirement, given this transition, that we do that. So I would, if all right, I would make a motion to accept, to approve action item number 7, with the accepting the errata as proposed by Dignity Health and the errata as proposed by the Department of Public and Behavioral Health.
Okay, there's a motion. Is there a second?
Can I get a point of clarification? Is there conflict between the two proposed errata? Okay.
Oh, I'm sorry.
Yeah.
No.
Okay, Mr. Smith seconded.
Yeah,
Further
Charles Smith
discussion or
second.
questions? Hearing none, all in favor of agenda item 7 with the both erratas that were mentioned by Dignity Health and our division, please say aye.
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 Opposed, say nay. Any abstain? Motion carries. Thanks, everybody. That was good discussion. Agenda item number 8, consideration and possible adoption of proposed regulation amendments of Chapter 458 of Nevada Administrative Code LCB file number R055-24, reflecting an omission of a complete set of fingerprints to the Central Repository for Nevada Records of Criminal History for submission to the Federal Bureau of Investigation for the handling of fingerprint cards and issuance of the reports of criminal histories. This summary of changes is an amendment to omit a statement that will best align with the governor's executive order for regulations to the application for certification of a detoxification technician in NAC 458.342. Shannon Bennett, please.
Good morning, board members. My name is Stephanie Cook, and I serve as the Deputy Bureau Chief of the Bureau of Behavioral Health, Wellness, and Prevention within DPBH on behalf of Shannon Bennett, Bureau Chief. I am here to present our 055-24 for consideration. These draft regulations are a result of the Governor's Executive Order 2023-003, in which state agencies were asked to complete a review of their regulations and consider removing unnecessary regulations to better streamline processes. The Bureau of Behavioral Health, Wellness, and Prevention currently certifies substance use prevention, treatment, and other related programs statewide. In 2015, the addition of detoxification technicians were added to NRS 458.025 and NAC 458.341 through 352. This is the only certification that our Bureau certifies for an individual person. Detox techs are utilized in 24/7 residential treatment and withdrawal management programs to provide screening for the safe withdrawal from alcohol and other drugs in accordance with division criteria and to obtain and monitor vital signs of clients. They play a vital role in closely monitoring clients during an important time in their healing process. We are requesting to remove the requirement of a complete set of fingerprints to the Central Repository for the Nevada Records of Criminal History, as outlined in NAC 458.342(2)E, for two reasons. First, our Bureau received guidance from our Deputy Attorney General that because the authority to seek background checks does not exist in statute, the program is unable to access background checks conducted under this regulation, and thus the program does not utilize this section. In addition, we have received feedback from our agencies that this is a duplicate process, as the agency already conducts background checks on the individuals prior to hiring them. We intend to request that the agency adhere to the same criteria in which a person may be deemed ineligible for hire as used in other instances of certification. In removing this requirement, the certified agency would need to maintain background documentations for their employees and can consult with the Bureau as needed. The individual applying for a detoxification technician would need to submit documentation from their agency that a background check was completed and the individual does not have any prior offenses that would disqualify them from certification. The Bureau will utilize this information along with other required documentation to process the application and issue a certification for the individual. Happy to answer any questions the board may have. Thank you for your time and attention.
Any questions from our board members? Thank you. Is there any public comment on agenda item 8?
We show no
There's
public comment in the north or online.
Thank you. There's no public comment in the south. I'll ask for a motion, please.
Joe Smith, I make a motion to adopt the proposed regulation LCB file on number R055-24. As submitted.
Mr. Cartwright, second.
It's been moved and seconded for approval. Any discussion? All in favor, please say aye.
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 Opposed, nay. Any abstention? Motion carries. Agenda item 9, consideration and possible adoption of proposed regulation amendment of Chapter 228 of Nevada Administrative Code LCB file number R121-24 to establish fees for licensing and regulation of domestic violence treatment programs. Letitia Metherell, please.
Okay. Chairman Pennell and members of the board, for the record, my name is Letitia Metherell, a health program manager for the Bureau of Healthcare Quality and Compliance. The Bureau of Healthcare Quality and Compliance certifies domestic violence treatment programs. The proposed regulations were moved forward in accordance with NRS Chapter 233B, the Nevada Administrative Procedure Code. The division sent small business impact questionnaires to programs for domestic violence treatment and concluded that the proposed regulations will result in a financial impact to programs because currently there is no fee. And once the proposed regulations become effective, these programs will be required to pay the applicable fees. Based on the feedback received via the small business impact questionnaire and 2 public workshops, it is believed that the fees will not result in a significant financial impact that would result in programs closing or prevent new programs from opening. Currently, domestic violence treatment programs do not have any fees associated with the work to certify and regulate domestic violence treatment programs. The proposed regulations establish such fees. Licensees fees collected from other entities licensed by the division's Bureau of Healthcare Quality and Compliance support the work to certify and regulate these programs. The first public workshop was held April 2nd, 2024, and a second public workshop was held on July 31st, 2024. At both public workshops, there were questions and clarifications requested on the imposition of the fees, but there was no oral or written testimony indicating that the proposed regulations would pose a financial hardship on the industry. Section 1 establishes a $598 fee for an initial application, a $245 fee for an abbreviated application to operate another program, and a renewal fee of $299 a year. It also establishes a $150 fee for a certificate for a program located in another state and a renewal fee of $75 for a program located in another state. Section 2 establishes a fee of $39 to process changes to applications pursuant to this section. It also establishes an additional fee of $39 if the program notifies the division of any required changes more than 30 days after such change is made. Staff recommends the adoption of the proposed regulations, LCB file number R121-24. This concludes my testimony. Are there any questions I may answer?
Thank you. Does the board have any questions? Is there any public comment? There's no public comment in the south.
Kelly Knudsen, for the record, we have no public comment in the north or online. I do want to mention that both Dr. Ponce and Ms. Belza Vinua are online. They are having issues with being unable to unmute themselves, but they are present for the meeting.
Okay, thank you very much. Chair calls for a motion for action, agenda item number 9, please.
Dr.
LCB
Morosky.
file number R121-24.
Dr. Morosky, motion to approve LCB file R121-24 for fees to establish licensing and regulation of domestic violence treatment programs as proposed.
Charles Smith, second.
Moved and seconded. Further discussion? All in favor, please say aye.
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 Any opposed? Nay. Any abstention? Motion carries. Agenda item 10, consideration and possible adoption of proposed regulation amendment of Chapter 652 of Nevada Administrative Code, LCB file R145-23, to revise current language that refers to completing applications for laboratory licensing or laboratory personnel licensing or certification. Mr. Bradley Wapple.
Chairman Pennell and members of the board, for the record, my name is Bradley Waples, WAPLES, Health Facility Inspection Manager for Medical Laboratory Services of the Bureau of Healthcare Quality and Compliance. I am presenting for your consideration proposed regulation change LCB file number R145-23 regarding changes and updates to Chapter 652 Medical Laboratories. The proposed regulations were processed in accordance with NRS and NAC Chapters 233B, Nevada's Administrative Procedure Act. The proposed regulation changes were drafted to update language in the Nevada Administrative Code, Chapter 652, to include licensed optometrists as laboratory directors of laboratories performing tests that have been categorized by the FDA as waived pursuant to Nevada Revised Statute 652.210. To update regulatory requirements for the qualifications for affected personnel licensure and certification so that it will be aligned with the changes in the federal Clinical Laboratory Improvement Amendments, or CLIA, requirements for personnel, which will change on December 31st, 2024, and to repeal an unused regulation to comply with the Governor Lombardo's Executive Order 2023-003. Section 1 clarifies the requirements for laboratories to submit an application, pay the associated fee, and have an inspection when they are changing the name of the laboratory, adding new tests to their test menu, or if there is significant change in the methodology in which the laboratory is performing testing. Sections 2 through 7, 17, and 23 through 25 updates the language from stating that applications must be on a form, which could be construed as a hard copy form, to state that an application must be made in a form that is prescribed by the division. This language will address the current way that applications are submitted, which is online through our Nevada website, and will also not require regulatory language change if there are future changes in the way the division accepts laboratory or laboratory personnel application submissions. Sections 8, 9, 11, and 12 removes the qualification of an educational doctoral degree in a physical science or a licensed laboratory director, a registered laboratory director, and a general supervisor of a licensed laboratory. For a clinical laboratory technologist certification, the removal of education in a physical science are for those who have earned a bachelor's degree. The reason for this removal as an educational qualification is due to being aligned with the federal CLIA program, which will be removing the degree in a physical science from the acceptable qualification for laboratory directors and testing personnel because they consider the degree in a physical science as being too broad of a subject in which may not adequately cover laboratory medicine. This federal change will become effective on December 31st, 2024. The state regulation will become effective January 1st, 2025. Section 26 addresses all persons that currently hold a laboratory personnel's license or certification that was approved through the qualification of having earned a degree in a physical science to continue to be eligible to continue their licensure or certification if all other qualifications are met. Sections 8 and 9 provide an update regarding an additional organization approved for the certification of persons who have an earned doctoral degree to be qualified laboratory directors. A federal CMS memo was sent to the state agencies on July 24, 2023, stating that the federal CLIA program has approved laboratory directors that have been certified by the American Society of Clinical Pathologists, or ASCP, to be qualified as laboratory directors of laboratories that perform high complexity testing. Their certification would be for a diplomat in medical laboratory immunology, or DMLI. This information was brought to light during the public workshop for R145-23 on July 12, 2024 by a participant. The information was confirmed and added to the R145-23. Section 10 adds licensed optometrists as qualified laboratory directors of laboratories that perform laboratory tests that have been categorized by the FDA as waived laboratory tests. This regulation change is due to the passing of the Assembly Bill 432 during the 2023 legislative session, which added licensed optometrists to the Nevada Revised Statute, or NRS 652.210. Sections 13 and 14 updates the qualifications for a person seeking a laboratory certification as a histotechnologist or a histologic technician to be qualified if they have completed an accredited program in histotechnology. The current regulation states that the person would need to complete a program that has been certified by the Committee on Allied Health Education and Accreditation. This required the regulation to be changed since the certifying organization of the Committee on Allied Health Education and Accreditation no longer certifies programs for histotechnology. Section 14 also adds that a qualification for a histologic technician to be a person who has a national certification as a histologic technician. Section 16 adds a person that is qualified for a point of care analyst certification to be a person that is enrolled in a practical school of nursing or has graduated pending the results of their first licensing examination scheduled by the Board of Nursing. Section 17 reduces the time in which temporary employment may be granted from a period not exceeding 12 months to a period not exceeding 6 months. In addition, a laboratory personnel applicant will have up to 30 days to complete their application with any missing documents or required information to have their application approved once the division is reviewed and contacted the person of the missing information. The ability for our agency to have an online application process for laboratory personnel applications has allowed for the credentialing staff to have decreased turnaround times for the approval of submitted applications. Section 18 is updated to address that persons that hold an office laboratory assistant certification and is performing moderate and or high complexity laboratory tests, that the laboratory director is responsible for ensuring that the testing personnel also meet the federal CLIA requirements for testing personnel found in 42 Code of Federal Regulations 493. Section 19 updates information as to what information is provided in the notice to a person holding a laboratory personnel certification or licensure for the renewal of their license or certification. Section 20 adds a certification in molecular biology as an acceptable qualification for a laboratory personnel certification as a technologist with a specialty. Section 27 repeals NAC 652.600, which indicates the requirements for a program of training for certification as a technician. This regulation has not been used for at least 12 years and is being repealed in accordance with Governor Lombardo's Executive Order 2023-003. Since the requirement for a laboratory personnel certification as a medical technician requires the person to pass a national exam, the certifying organizations each have qualifying requirements to sit for the certification exam. This regulation would not be required to ensure that the person met the requirements if the person has passed a national exam. The staff recommends the Board of Health adopt the proposed regulation amendments to the Nevada Administrative Code, NAC Chapter 652, LCB file number R145-23. This concludes my remarks at this time, but I'm happy to answer any questions or concerns.
Thank you. Any questions from our board members? Thank you. Apologize for, I should remember how to pronounce your name, but I butchered it a little bit there.
Sorry.
I butchered your last name a little bit. I apologize. So I should remember.
First.
Is there any public comment on agenda item number 10?
We have no public comment in the north or online.
No public comment in the south. Chair calls for a motion on agenda item 10, LCB file R145-23.
Mr. Cartwright, for the record, I move to approve the proposed regulation amendments.
Charles Smith, second.
Moved and seconded. Any discussion? All in favor, please say aye.
Aye.
Aye. Aye.
Opposed, nay. Any abstain? Motion carries. The next two agenda items are election of a board chair and a board vice chair. We do have a quorum. Ms. Takis, would you like to comment on what you recommend for us to proceed since we have two members that are not able to vote?
Sure. So I just want to make a record of what was noted right directly before the previous item. There's two members that are having difficulties with their audio. So for purposes of the open meeting law, they are not counted towards quorum because they're unable to participate in the meeting. That said, all actions that have been taken during this meeting are still valid because there are a quorum of members that are active and participating in this meeting. So the next two items are on the elections of the chair and the vice chair. So I leave it to the current chair's discretion on whether or not he would like to table those items for a future meeting with full attendance.
This is basically an internal thing to elect leadership. The chair elects to go ahead and pull 11 and 12 so we can get full board input next time. So we'll table agenda item 11 and agenda item 12. Agenda item 13 is recommendations for future agenda items. Are there any recommendations from our board? Is there any public comment?
We show no public comment in the north or online.
There's no public comment in the south. And agenda item 14, we'll open the floor to public comment on anything that they would like to comment on. And there is nobody in the south currently in the room.
We have nobody in the north or online.
Okay, thank you, everybody. Appreciate it. Have a good weekend. This meeting is adjourned.
Thank you.